became involved with the whole idea of MCPs because general practice was in crisis. We had a huge problem in Gosport, particularly around GP recruitment. A lot of GPs were drowning in work.
Sorting room 3.
One of the solutions around these challenges is better integration across services. So if one was to imagine a world where general practice is working more closely with acute outpatient services, with community services, with mental health services, with social care, one might experience as a patient a better journey. We're better able to design clinical pathways more effectively and more seamlessly. We may drive better use of our resources, whether that's human or financial, and hopefully achieve better health outcomes.
Hi. Can I help you?
Yeah, I've got an appointment with Dr. Fraser.
We've put a lot of energy as an MCP into improving access to primary care for our patients.
If you'd like to go and take a seat in the waiting room.
From standardising opening hours across all our practices, and we're now working together as a group of practices to offer evening appointments and weekend appointments, particularly targeting people with mental health problems.
We became interested in forming an MCP because we have a model of care here in Dudley which involves wrapping care around patients wherever possible in the community, and where possible moving hospital-based services into a community setting.
There's no obligation on the part of any GP or general practice to participate, but what we would say is that general practice is an essential element of an MCP. The three options include a virtual MCP, which means that the practices don't change from their existing contracts, but there is an alliance agreement that sits on top of but does not supersede their traditional contracts, which is between commissioners and other stakeholders in that system. Another option is a partially integrated MCP, where the Commissioner issues an MCP contract that includes the scope of the services included, such as community services and mental health, but not including general practice, and GPs and their practices would continue working through their existing contracts, but they would sign an integration agreement. A third option is a fully integrated MCP contract, which includes a scope for all of the services, including general practice. GPs will want to know some of the details, so for example their opportunity to become shareholders or stakeholders within the ownership structure of the multispecialty community provider, or they may choose to become an employee of the organisation, in which case their terms will be at least as favourable as those of the BMA contract. Their pension situations are secure, and actually the fact that if they're in a fully integrated multi-speciality community provider, that the indemnity will be held at the organisational level.
A model of care based on people. We've been quite surprised because we had the idea that mainly GPs wants to look at partial integration as a model of care. Actually, there's been significant interest in a full integration model because people believe in the MCP process. Please understand.
GPs within a locality will all need to decide what is the right decision for them, and not all practices will necessarily need to decide to be all in or all out. GPs are finding that working together gives them an opportunity to take back control of their workload. For example, the GPs in Gosport, where they're focusing on their urgent care activity.
What we've done locally is, for the practices that were under real pressure, we looked at what was the issues and building the extended primary care team. Looking at the work that a GP does and saying, this portion of your work you probably don't need to do. So we shifted some of the urgent care work to this place, which is the same day access service, where people can phone up on the day, say, I'm ill, I need to be seen, and they'll have a consultation over the phone, and then if they need to be seen, they're brought in here. But 60% of patients are actually sorted out on the phone. No spinning, vertigo. Back in the surgery, we've got a controlled workload with longer appointments, so we've longer times to deal with those patients who need complex decisions making. It really is personally gratifying for me to be able to do the job I was trained to do.
GPs are also finding that actually working within MCP type arrangements gives them opportunities around developing their clinical skills in particular areas or taking on leadership roles within the organisation.
I am seeing more and more support for clinical leadership, and I'm being more and more supported by my colleagues from different organisations as well as within our local CCG.
They're really concerned that her memory has deteriorated.
And if that support continues to grow, it will attract other local GPs into a leadership role, which in turn will make my role easier.
MCPs are giving groups of clinicians and managers the opportunity to think about some of the more practical issues that they're facing. For example, around building strategy, around IT, around how the back office of a group of organisations are structured. In Manchester, the MCPs are being seen as a formal way to bring together partners to tackle some of these challenges.
We have to make sure the estate is fit to deliver the new ambition and not the current state of play. It's driven us to talk and communicate in a way that we've never done before as practitioners and providers. So therefore we can either share estates or we can work on solutions together instead of just being our individual bespoke practices.
Integrated working and multispecialty community providers being a way to get there offers us an opportunity to develop a new architecture in the system, an optional contract on the part of general practice, but a real chance to work in a really different way with colleagues across the system and create a bigger voice for general practice, different career opportunities across a wider body of entities that are working in an aligned way, and actually also provide patients with a materially different, enriched offer of care and a different experience from how they interact today.
Doing nothing is no longer an option. We're going to end up in a much worse state if we don't do something with this. We need to get the system leaders around the area to say, actually, this makes sense.
We've actually got a new service now. I'm convinced things are getting better. Patients tell me that that's the case, and their families, and the care home staff and the other health workers that we work with are all convinced of that as well. They tell me their stories and they give me examples every day of how that's working.
Seriously deteriorated within the last 6 months.
Working collaboratively and working with the other people that provide care for our patients is the way that we want to move and we want to change in moving forward.